happy to be here with you and share my experience, and I will try to convince you that the right ventricle is really important. So I don't know if maybe this is enough, right? This it doesn't. So Medellin, I think it's a nice city. It's my first time in Colombia, but of course also in Medellin. I was a little bit scared, you know, because of all the movies. But during the trip, during the tunnel, so Silenia told me lots of beautiful things about the city. So now I love the city, and I'm very happy to be here. So I will start with the agenda. I promise it's no more than one hour, okay? So the agenda is long, but no more than 1 hour. So we will start with risk assessment according to the guidelines. I know that you in Colombia are really happy with the guidelines, so we will start from there. Then we will touch the second point, behind clinical improvement. What is behind clinical improvement? The role of the right ventricle, the importance of reversing the structure and the function of the right ventricle during the course of the disease. And at the end, the relevance of comorbidity. You know, in the last guidelines, it's important to distinguish between patient with and without cardiopulmonary comorbidity. So we will touch this point in the last part of the presentation. So I will start with the guidelines. So something new for the European Society of Cardiology, and something new came from the Pulmonary Association, the Pulmonary Society of European Society. Because we have some cardiologists in the room, yes, so you know that usually the guidelines, the European guidelines for cardiologists, do not consider questions, PICO question or narrative question. We have a systematic review of the literature and then the recommendation, the level, the class of the recommendation, okay? But pulmonologists have something more, and I think it was good to share, you know, the guidelines with the European Respiratory Society, and something new comes from the clinical need. So they love to introduce the clinical need through important questions called PICO questions and narrative questions. So they start from a question, so should a re-stratification strategy be used to guide treatment in PH? That's what clinicians face in their clinical practice, so they want a recommendation for that question. And this is something that we are not used to, so very nice in PH to have this new kind of guidelines. And you see, this is important because for two reasons. We have a positive recommendation, so we have to use the risk scores that we have. But however, the evidence is moderate because the accuracy of the risk scores are moderate. And this is important because make you better understand the final recommendation. So use the scores, but it is recommended to evaluate the patient with a panel of data coming from whatever you need, in particular hemodynamic and imaging. So the recommendation is start with a score, but do not forget to use what you have on your hands, in particular imaging, and that's good for cardiologists, and invasive hemodynamic. And the second reason is that you now have the gap of evidence. So the scientific community can work to improve the knowledge and come up with new evidence that can be used in the next guidelines. So you know what is the gap of evidence to fill the question. So to improve the accuracy of the available scores. So all the community knows this is a gap of evidence, and they can work on that for the next 5 years. So two reasons why the questions are so important in the guidelines. So first, we know that at the time of diagnosis, the recommendation is to use the 3-strata model of the guidelines. And in the 3-strata model, we have, in the famous table, the colored table, we have more details on some parameters. On the echo, we have the TAPSE or the systolic pressure, that, you know, it's a surrogate of RV coupling to the pulmonary circulation. Then we have lots of parameters for MRI, and we have the stroke volume index for the hemodynamics. But we also have a supplementary table. I worked very hard for that. And you see, for MRI and echo, we have now many parameters with cutoff values for increased risk and decreased risk. And you see it's about morphology, systolic function, filling pressure, and the synchrony. So we can use them to improve the risk stratification of our patient in our clinical practice, okay? Then, during the follow-up of the patient, it is recommended to have a 4-strata model, and this is something new. It comes from the Compera registry, the derivation court, and then we have the validation court from the French registry. And you see 4 strata with just 3 parameters. 3 parameters coming, 2 of them from the reveal and the other one from a log rank test, choosing the cutoff value with the lowest p-value, okay? So 4 classes. Again, it is recommended to use it as a basic tool with additional variables from hemodynamic, imaging, genetic, and so on. So these were the two cards, the derivation one and the validation one. You see that the 4-strata model is able to have a better discrimination of the patient. But however, remember, and I will show you that this is relevant, it is about survival, okay? So this means that we have to bear in mind that we have a prognostic model, but with this prognostic model, only a minority of patients is able to improve to a low-risk condition. That is the treatment goal that we have. And in a short-term follow-up, because this was the median 4 months, so 50% of the patient had a follow-up at 4 months or less. And you see, between 15 and 20% of the patients will deteriorate to a greater risk profile. This means that 1 out of 5 patients are going to deteriorate within 4 months, whatever is the treatment strategy that I use for that patient. So we have to stratify the risk of the patient. However, we have to remember that 20%, 15, 20% of the patient are going to deteriorate, whatever is the treatment strategy that I choose for my patient. And this was confirmed by the validation court. You see, between 15 and 20%, and the deterioration is included for the low risk strata. You see the low risk and the intermediate low. So being at low risk or at intermediate low risk doesn't mean that the patient is not going to deteriorate. So we have these tools, but the accuracy is moderate. And that's because we have an optimistic prognostication. Because of missing data on clinical worsening, it's just about survival and disease progression. We have low sensitivity, low negative predicted value. We are not able to highlight those patients that are going to deteriorate. So very low sensitivity and negative predicted value. And then we have to keep in mind that the treatment response within the same class is heterogeneous. So we need to improve. That's a gap of evidence. We have to use them, but we have to remember that there are limitations and we need more. So what's behind the clinical improvement? So this is the recommendation of the guidelines. When you have naive patient without comorbidity, cardiopulmonary, not just comorbidity, but cardiopulmonary comorbidity. If the patient is at high risk, you have the triple combination, including the parenteral prostanoid. And for low and intermediate, we have the double oral combination. So this is an aggressive approach for the patient without cardiopulmonary comorbidities. However, this is the first study I want to show you from the Italian network. So networking is so important. It improves the clinical evidence and allows guidelines to improve every 5 years. So the study was about 181 naive patients treated with the double oral combination among 11 Italian centers. This was the most common combination. And you see, using the two scores, the European one, the compare one, and the reveal one, this was the time of diagnosis, so low, intermediate, high risk. And this was the changing in the risk profile of the patient at a median follow-up of 6 months with a double combination. So you see, first important message, if you are high risk, no chance to improve to low risk profile. So for the high risk, the double combination is not recommended. Then we have the intermediate, and you see in the intermediate risk group, less than half of the patient with the treatment recommended by guidelines for the intermediate group, less than half will achieve a low risk profile. And for the low, you see these are low patients, low risk patients at the time of diagnosis, and a significant proportion of this patient, maybe around 30% of this patient, 1 out of 3, in 6 months are going to deteriorate with the double combination. So remember, the treatment response is heterogeneous, and we have to better understand and discriminate among patients in the same class of risk, the intermediate and the low, which patient needs to be treated maybe more aggressively. So the meaning of that, the reason of this heterogeneous response comes from the pathophysiology. So this is an afterload mismatch disease, and we as cardiologists are very happy for that. And you see, so with the double oral combination, we have an heterogeneous response in terms of pulmonary vascular resistance reduction. And the median reduction is 40%, but you see you have some patients that may even progress during a double combination. So if you look at those patients able to improve, to move to a low risk profile, the characteristic of the patient that improved or maintained a low risk profile are those able to significantly decrease pulmonary vascular resistance. So the way to improve and move in a better risk profile is to the reduction of the RV afterload. And this is true whatever was the scoring system we used, the European one or the United States one. So that's because if you consider all the variables that are included in the risk scores, the variables, the right atrial pressure, the cardiac index, walk distance, functional class, the BNP or the pro-BNP, all of them are indirect signs of the behavior of the right ventricle. So that's why you are able to improve and move in a better risk profile status, because of these variables that come from the functionality of the right ventricle. So looking at the problem from a different point of view, so from cluster analysis, we're used to for prognostication to have Cox multivariate analysis, but to look more in deep on the pathophysiology of the disease, cluster analysis is, I think, the best. So we started, this is from my center and a center from the United States. So we start with 30 baseline variables, including, you see, the demographic, the clinical history, the echo, the cardiopulmonary exercise test, and so on. So many variables, but when you go to the discriminant function coefficient, that identify those variables able to clusterize all the group of the patient. So the nearer is the coefficient to 1, the closest to 1, the better is the ability to clusterize. So 3 are the variables. The best variables came from pathophysiology. So we have mean pressure, that means afterload, RV afterload. Then we have the oxygen pulse. You know, the oxygen pulse is a surrogate of the stroke volume, okay? And then we have the end diastolic area. So it's the afterload that the right ventricle have to face to guarantee the cardiac output. So using this tree, you were able to clusterize all the group of patients. So we have, you see, these 2 clusters, low RV afterload, mild PH, mild dilation. So we as cardiologists know that an end diastolic area less than 25 is a mild dilation of the chamber. And then we have the exercise capacity, low and preserved. So these 2 clusters. And then we have the high afterload clusters, you see, the blue and the red. So high MPAP, severe dilation, and again, preserved or reduced exercise capacity. So building the Kaplan-Meier curves. But before, just a couple of words for the clustering. You saw the 4 clusters. So we have preserved RV adaptation, a preserved RV phenotype, an adaptive phenotype, and a maladaptive phenotype. So the blue and the red are adaptive or maladaptive, so advanced stages of the disease. And you see, looking at the Kaplan-Meier, you have that the advanced stages have a worse prognosis. This is not survival, it's event-free survival, so it's clinical worsening. So we wanted to better understand the importance of clustering patients according to pathophysiology, considering the scoring system. And we went back to the European score, and you see for the high-risk patients, the score is able to identify really the group of patients at higher risk, the blue and the red, so the advanced stages of the disease. So high specificity, high positive predicted value. But for the intermediate and the low, you see, we have inside all of the groups. So it may be intermediate, and we have inside maybe 18% of patients that are really at low risk, but we also have 45% of patients that are high risk. And the same for the low. We have 45% of really low risk patients, but we also have, you see, 15% or 25% of those at higher risk. So there is something missing in the risk score that we have, that is the pathophysiology of the disease. Because the scores are built up just from indirect variables. And the same was considering the French approach. You know, the French likes to have at least 3 low risk factors to have a low risk profile of the patient. And again, if we consider those having 3 low risk factors, you see again, we have many of the patients, or at least a significant proportion of the patients that are at higher risk. So we need to improve the discrimination of the scores. Again, looking at the reveal, the final message is always the same. There is pathophysiology missing, and the way to gain pathophysiology in the score is looking at the right ventricle. So that's why, and this is the other work from the Italian network, we retrospectively considered 1,015 incident patient with PH, and based on an a priori, let's say, identification of 4 different phenotypes, RV phenotypes. So it is an a priori phenotyping based on pathophysiology. We have 4 groups of patients. So here we have, you see, a mild dilation of the right ventricle, so end-diastolic area of the right ventricle over the left ventricle in 4-chamber apical view. Less than or equal to 1, that means mild dilation. And then we have a tap over systolic pressure greater than the cutoff value considered by the guidelines, whatever is the tricuspid regurgitation. Okay? So, phenotype 1, let's say a preserved RV phenotype. Then we have the second phenotype, so we have a mild dilation of the right chamber, whatever is the tricuspid regurgitation, mild or moderate or severe, but we can have uncoupling. So the tapsi over the systolic pressure is low. Then we have the third one, severe dilation, you see, with preserved coupling, again, whatever is the tricuspid regurgitation. And then we have the fourth one, the most prevalent, that's why we separated mild to moderate tricuspid regurgitation and severe tricuspid regurgitation. So severe dilation and uncoupling. So 4 phenotypes. And then we looked at the phenotypes according to pulmonary vascular resistance, to the afterload. So you see the first 2 phenotypes, the less advanced phenotype, have lower pulmonary vascular resistance, while the other have higher pulmonary vascular resistance. Okay? So in a median of 3 years, 1/3 of the patient died. So let's see who were the patient dying. So this is the European score. You see low, intermediate, high, and high. So we have the phenotypes, the number of patients. So the majority, you see here, the majority of them are intermediate high and intermediate low. And then we have, you see, the cycle. You see the patient that are going to die within 3 years as a median. And you see this phenotype, for the phenotype number 4, half of the patient are going to die, whatever is the risk strata of the patient. So for low risk, if you have a 4 phenotype, 1 out of 2 are going to die. For the high risk, again, 1 out of 2 are going to die. And for the first one, you see very few patients are going to die. Even for the high risk, 1 out of 5 of the patients are going to die. So this means that if you look at the right ventricle, that means looking at pathophysiology, you will have more information on your patient risk, independently of the strata considered for the patient. And of course, this is the European one, but we looked also at the REVEAL one. So you see, this is REVEAL, and the message is the same. It is just one thing changing, that is when you have a very high REVEAL, more than 10, you see you're going to die, whatever is the phenotype. So there's something more in the REVEAL when it's more than 10. However, those patients with a REVEAL more than 10 is probably less than 5%. So very few patients. You see here in 1,015 patients, it was 26 or 28, okay? So I think this is important. And that's the reason why, if you look at the phenotype, you will be able to see, and this is again from the Italian network. You see how many things you can do when you have networking in your country? So these were at least almost 700 patients with 2 observations. So here we have the TAPSE over the systolic pressure at the second observation, whatever was the treatment strategy used for the patients. And these are the number of variables that have improved with your treatment strategy. So we know that to improve to a low risk profile, we have to improve the variables. So looking at the number of variables that improved, 1, 2, 3, or 4, you see that's a function, again, whatever the risk score, it's a function of the improvement achieved on the right ventricle. So you know that a normal right ventricle has a TAPSE over systolic pressure more than 0.5, okay? And we know from the guideline that the prognostic cutoff is here 30, 35, okay? Point. So if you're able to improve RV coupling, you will be able to improve the number of variables in the scores. And that's easy to understand because the variables are the indirect sign of the improvement of the right ventricle. So if this is clear enough, then this is maybe a little bit more busy. However, I will make it simple. So looking at those, this is the improvement in pulmonary vascular resistance at the second observation, and this is the TAPSE over systolic pressure at second observation. European score, review score. So look at the dark green cycles. To improve to a low risk condition, that means you are at intermediate at least. You see, you need to have a good improvement of the TAPSE over systolic pressure and a significant improvement of pulmonary vascular resistance. To maintain a low risk, the light green, this means that you are already at low risk at the beginning. To maintain, you may need a less degree of reduction in pulmonary vascular resistance, but this is because your right ventricle is already good, okay? And indeed, you see, if you have to improve the coupling of the right ventricle, you have to achieve an important reduction in pulmonary vascular resistance. So if you are not able to achieve an important reduction, as it was for those patients at a low risk profile, and you maintain the improvement, is because your right ventricle is already good. But if you have to improve, you need to significantly reduce the afterload. And indeed, considering adding the right ventricle, you see here the TAPSE over systolic pressure, you see you are able to better discriminate the intermediate risk group and the low risk group. And you see the improvement in the discrimination, whatever is the score, and this is not just about survival, but is event-free survival, so it's clinical worsening. We do not want our patient just to survive, but to survive at least without clinical worsening, without deterioration. So now is, I hope, more clear how important is the role of the right ventricle if we want to stratify our patient, and the limitation of the current scores, okay? But now something more, a step forward. The importance with the treatment strategy to improve and have a reverse remodeling of the right ventricle. So this was initially a study from my center, 100 patients. We looked at the patient after 1 year, whatever was the treatment, and looked at the 3 simple echo parameters, diastolic area, right atrial area, and the eccentricity index. We combined in a score these 3 parameters and looked at the additive value, because this is when we use imaging, what I want is to have an additive value on top of what I already use. So I use the scores, so I want something more. And that's why I wanted to show the additive value of echo at follow-up on top of the reveal score. And you see, adding echo, we had an improvement of the prognostic information of the model. And this was because, looking at the Kaplan-Meier, if you are able to have a reverse remodeling, whatever is the risk profile, considering the reveal, you will have a very long prognosis. You see, again, event-free survival. But even if you improve the reveal score, you see that the line reveal less than 7 or equal to 7. You see, the prognosis will be bad unless you have a reverse remodeling. Because this is really what we want. So we have initially this kind of RV dilation, and this is what we really want for our patient. So when I look to the patient, I don't want to see the patient walking maybe 20 meters, 50 meters more. Okay, that's good, of course, but if the patient walks 50 meters more and the right ventricle is the same, that means that I was able just to improve cardiac output with a small reduction in pulmonary vascular resistance. So when we improve cardiac output, the patient will feel better and walk more. But however, I didn't change the clinical history of the disease. So I want to see this when the patient comes back to the clinic. And to have a reverse remodeling, you see that the probability is about afterload. Again, the curve is sigmoid. This means that I will not be able to change the structure and the function of the right ventricle, you see, unless I are able to reduce pulmonary vascular resistance up to 50%. Then, from 50 to 60, the probability is really very high. So we will be able to achieve a reverse remodeling for probably most of our patients, but no way for lower degrees. So again, a study from the Italian network, we used matched cohort of patients. That means that the demographic characteristic, functional capacity, invasive hemodynamic, and echo at baseline are exactly the same, but different treatment strategy. You see the oral monotherapy, the double oral, and the prostanoid plus 1 or 2 oral drugs. So same characteristics, and look at the improvement of all those variables included in the scores. So the functional class, the walk distance, right atrial pressure, and cardiac index. So whatever the strategy, we have a significant improvement of the variables. So that was the reason why all the drugs have been approved in the market, because one of these variables, the functional class, was the primary endpoint of the phase 3 trials. And the pulmonary vascular resistance was the primary endpoint of the phase 2 trials. So you see, they all improved. However, if we look, because I have convinced you that we have to look to the right ventricle, right? So I don't want to know if the indirect variable have improved. I'm happy with that, but I want more. So if you go and look to the end diastolic area and fractional change, you will see that, you see the strategy that the blue circles are the oral monotherapy, the red one are the prostanoid, parenteral prostanoid plus oral, and the yellow one are the double oral combination. So you see, for the oral, low reduction in pulmonary vascular resistance, no change in end diastolic area, and fractional change. So we are able to improve the walk distance, the functional class, the cardiac index, because of a mild reduction in pulmonary vascular resistance and a mild increase in cardiac output. And however, if we want to improve the size of the right ventricle and the systolic function, you see we have to gain more. So 50–60% reduction in pulmonary vascular resistance, huge improvement in end-diastolic area, and fractional area change in a follow-up of 4 to 6 months. And of course, we will improve the patient risk profile. So these are, again, the treatment strategies, the risk profile of the patient at the beginning, intermediate, and high. You see, with the oral monotherapy, just few patients are going to improve to low. And for the more aggressive approach, you see, whatever the initial risk, 30% of them will improve. And when we are really aggressive, so a triple combination from the beginning, here was 2 drugs and the treprostinil, you see the range between 26 and 92. You see how important is the difference compared to the oral monotherapy. So up to, you see, from 50% to 90% reduction in pulmonary vascular resistance. And of course, you have the improvement in all the other indirect parameters, including the scoring system. And that's why, because this was a position paper, it included as authors all the more important names in the world. And you see, it was a common thought that compared to the double oral combination, when you are more aggressive, you will be able to achieve more in terms of reduction in RV afterload, pulmonary vascular resistance, and mean pressure. And you see, coming back to the strategy, this is just from my center, but however, you see here different strategies. So a parenteral prostacyclin plus 1 oral drug or plus 2 oral drugs, and the add-on prostacyclin. So you start with the oral, and then you add a parenteral prostacyclin. And you see here is, again, the reduction in pulmonary vascular resistance, and here you have the end-diastolic area. So you know, or at least we are cardiologists, so we know, and we will share with you. When the end-diastolic area is less than 25, we have a mild dilation. So you see, with the upfront strategies, many patients are going to improve to a mild dilation of the right ventricle with huge reduction in pulmonary vascular resistance. But with the add-on strategy, you see, most of the patients will not be able to improve the right ventricle because of the mild improvement in pulmonary vascular resistance. And indeed, this was from 3 centers, the Japanese, Matsubara, Irene Lang, that you know, from Vienna, and our center. So more than 200 patients. You see mean pressure at diagnosis and at last observation. So you have the identity line. So you know that if the mean pressure is going to increase during the follow-up, most of these patients are going to die, whatever is the treatment strategy. But for those that will reduce mean pressure, there is a big difference in this group and this group. You see, when you have a very low, so a big improvement in mean pressure at the last observation, you will have no deaths, no cardiovascular deaths. You know, the patient, these are the 4 or 5 patients died because of cancer. And again, this is because if you want to improve the mean pressure, reduce the afterload, you see the different relevance of the strategies. From the oral monotherapy, no way. From the triple combination, you see how it's much easier to improve RV afterload over time. And when you are able to improve the mean pressure at the last observation, you see the red one, and these are 15 to 20 years follow-up. You see how important this is survival. So patients are going to survive you see the difference between those patients that were not able to improve the mean pressure to a mild disease. And to be able to improve mean pressure, you see here less than 25 at the last observation. You see how important is the timing from diagnosis to the beginning of the parenteral prostanoid. You see very high probability when you use the upfront strategy, but if you want to add on after beginning with a double oral or a monotherapy, you have to keep in mind that you have to add the parenteral prostanoid within the first year. After 1 year, the probability to improve the hemodynamics is really low because the course of the disease has progressed. You see, if these are all patients treated with parenteral prostanoid, whatever was the strategy, upfront or add-on, and again, to normalize the end-diastolic area is a function of pulmonary vascular resistance, and when you're able to normalize end-diastolic area, you will no more have cardiovascular deaths in the long run, because here it's, again, 10 to 15 years. So that's the reason why it is highlighted in the guidelines that at intermediate and low, you have to start with a double oral combination, but it is not in the picture, it is in the text. If the hemodynamics is really impaired, a severe hemodynamic condition is, just as an example, cardiac index below 2 or a pulmonary vascular resistance more than 12. So if this is the case, even if you are at low risk or intermediate risk, you have to start, you should start a triple combination with a parenteral prostanoid. And for the follow-up, you see how aggressive is the treatment algorithm. Even if you are, after the first follow-up, in an intermediate high risk, you have to add a parenteral prostanoid. So you have the chance for the oral treatment, whatever is the treatment, the adding of selexipag or the shift to rioshiguat, there is the chance to optimize the oral treatment just for the intermediate low risk profile. And that's why this was an editorial from me and Michele Dalto from Naples. And you see, diagnosis, follow-up, we have a big intermediate group, but we think and we believe that looking at the right ventricle, if we have coupling, a good coupling, then we have the double oral. If we have uncoupling, we need to move to the parenteral prostanoid. And that's the same condition at follow-up. So coupling, add-on, optimization of oral treatments, selexipag, rioshiguat, but for the uncoupling, we have the add-on parenteral. So the last, so give me 10 more minutes. So for patients with cardiovascular comorbidities, we have a more safe approach. So we start from the oral monotherapy, and that's because looking at the ambition study, you see when before excluding those patients with cardiovascular comorbidity, obesity, diabetes, coronary artery disease, you see before excluding, the primary morbid mortality endpoint was not met. And it was not met the improvement in exercise capacity. And on the other hand, we have an improvement, you see, from 36 to 57, almost doubled, of serious adverse events. So that's the reason why it was, the task force want to recommend a more safe approach for those patients with cardiovascular comorbidities. So this was from the Compera. You see the left heart profile and the cardiopulmonary phenotype. So very few of them are able to improve to a low risk profile. So better to be more safe. But again, the Italian network wants to go a little bit more in deep. So that's the difference between cardiovascular comorbidity and non-cardiovascular comorbidity. For example, thyroid disease, okay? So you see, if we have non-cardiovascular comorbidity, no problem. We have baseline and we have follow-up. You see, cardiovascular comorbidity have the same behavior or no comorbidities, but cardiovascular comorbidity, they have a smaller proportion of patients moving to the low risk zone. However, it is 35% of patients. So 1 out of 3 patients with cardiovascular comorbidity are able to improve. So we can start more safe, but we want to improve, at least for this 35% of patients. See, the message is the same using the reveal. And who are those patients able to improve? Again, let's go back to pulmonary vascular resistance. You see the difference between non-cardiovascular comorbidity, no different in improving pulmonary vascular resistance. And then, again, if you want to look more in deep to cardiovascular comorbidities, you see that even if the improvement in the low risk profile is less important when you have comorbidities, cardiovascular comorbidity, the way to improve for that 35% of patients is exactly the same. You need to reduce the afterload. And again, this means that, I think this is maybe the 2 more slides, so I am really at the end. So we have to be more safe. Start with a monotherapy, oral monotherapy. Keep in mind that 35% of patients can improve to a low risk profile, and the way to improve is, again, reducing the RV afterload. And remember, this is the message, even if you have comorbidity, the patient in the short-term follow-up, this was 5 months follow-up as a median, so the patient, even with comorbidities, will deteriorate. So start safe, straight follow-up of the patient with cardiovascular comorbidity, because the patient is going to deteriorate, as it is true for those without comorbidities. And remember that you have to add drugs, because the way to improve is reducing the afterload. So finally, remember the low risk profile is the main goal for those without comorbidities, but even for those with comorbidities, maybe for some of them, half of them, maybe more, we will not be able to always improve to a low risk condition, so the decision to add the drug is based on an individual basis, depending on the patient. But however, some of them, at least a significant proportion, will be able to improve. The way to improve is reducing the afterload, so let's add on treatments in a straight follow-up, because they are going to deteriorate as those without comorbidities. So thank you for the long attention.